Assalamu alaikum. Recurrent sore throats caused by recurrent acute tonsillitis can be treated in one of three ways. You can treat conservatively each acute episode on its own, or you can treat with prophylactic antibiotics to prevent the recurrence of the sore throats, or you can do tonsillectomy. One important question is, at which point would tonsillectomy be the preferred option? The size of the problem of recurrent sore throats is big, and the sequelae of recurrent sore throats can be very significant on the families, the child and their families, and also on the healthcare costs. We can get an estimate about the size of the problem from several surveys, including this USA-based survey, which estimates that 1% of all children between the age of 4 and 15 years would have some recurrent episodes of acute tonsillitis in a 3-year period. The highest incidence, of course, would come in children between the age of 4 and 6 years old, and the prevalence of this recurrent acute tonsillitis would be about 11 to 12% of all children in this age group from all the other etiologies of acute pharyngotonsillitis. Besides the burden on the child and the family and on the healthcare, there are also problems with suppurative complications of acute recurrent tonsillitis, including quinsys and deep neck space infections, acute otitis media, and acute sinusitis, and also the non-suppurative complications, notably the acute rheumatic fever and the acute glomerulonephritis. Why do we face such a problem of recurrent pharyngotonsillitis? Inappropriate antibiotic therapy is one of the causes. Inadequate doses or duration of the treatment, such that you could get sometimes clinical cure but not bacteriological cure from the organisms that are residing deep in the tonsils. A patient can sometimes be non-compliant or non-concordant, and sometimes you can get reinfections from a nearby positive carrier. And of course, the problem of beta-lactamase producing commensals are important. Attempts should be made to identify any carrier in the family with throat and nasal cultures and to treat such carriers. Plus, of course, you can treat with antibiotics with intramuscular injections rather than oral in order to avoid the problem of non-compliance, and you have to change all the toothbrushes of the whole family to prevent reinfections from a positive carrier. Penicillin is the preferred first-line treatment in most national guidelines, but penicillin can fail sometimes in controlling the acute recurrent tonsillitis due to several factors, including inability to eradicate the intracellular group A beta-hemolytic strep, inability to achieve therapeutic concentration in the tonsillar surface fluid, and of course the beta-lactamase producing bacteria can also inhibit the action of penicillin, and the synergistic effect of group A beta-hemolytic strep with some organisms like Moraxella catarrhalis would, in addition to producing beta-lactamase, would also enhances the adherence of the group A beta-hemolytic strep to the epithelial cells and increase the chance of recurrence of the infection. The normal bacterial flora in the throat and the pharynx and the oral cavity has various mechanisms influencing the colonization of the pathogenic flora. So sometimes disturbance in the normal flora could lead to flourishing of the pathogens, because the normal bacterial flora behaves competitively with the pathogens, and suppressing the normal flora with any antibiotics could allow the other strains with pathogenic potential to flourish. This is called bacterial interference, and the best known interference example is the alpha hemolytic strep rather than the beta hemolytic strep. The presence of bacteria with interfering capacity is found in about 30% only of the children who have recurrent acute tonsillitis, whereas in children who don't have recurrent acute tonsillitis, the presence of normal bacterial flora would reach 85%. The three main treatment options for recurrent acute pharyngotonsillitis are either conservative management of each episode on its own, or prophylactic management with long-term antibiotics to reduce the rate of the recurrence, or tonsillectomy. There are valid arguments and some evidence with and against each of the three main options, and in this lecture we shall try and examine these evidence in order to identify at which point would the balance be tilted in favor of tonsillectomy option. For the conservative and the prophylactic antibiotics options, there are certain arguments against, including the development of resistant bacterial strains, the risk of adverse effects, including allergy, the promotion of candida infections, the failure to treat the bacterial infections because of inability to eradicate the intracellular group A beta hemolytic strep, or inability to achieve therapeutic concentration in the tonsil surface fluid, and of course the beta lactamase producing bacteria, as well as the increase in the prescription costs. On the other hand, the arguments against tonsillectomy includes this is a painful procedure that requires on average about 2 weeks to recover completely to return to work or to school, and that there is a high incidence of post-operative hemorrhage, about 6.37%, and about a quarter of these post-operative hemorrhage would have to return back to theater to sort out the bleeding. There is also a small but significant mortality rate of 3 in every 10,000 cases, and there is an readmission rate to hospitals after the operation, mainly because of the hemorrhage, but also sometimes because of the pain in 12% of the cases. And of course, tonsillectomy does not prevent acute pharyngitis by inflammation of the pharyngeal other structures with bacteria or viral inflammation, and a spontaneous recovery may be expected in some patients who had the surgery. The break-even point, the economic break-even point for the cost of tonsillectomy versus the cost for conservative or antibiotic management is more than 2 years, including the cost of the treatment and the cost of being off work. It needs about 2 years, more than 2 years, for the tonsillectomy option to break even. This break-even point of 2.3 years after tonsillectomy was estimated from a USA study, including the cost of the medical treatment and also the cost of being off work related to recurrent tonsillitis. Complications after surgery are quite substantial sometimes. In 2 of the largest North American cohort studies, including 42,000 operations, it showed post-operative hemorrhage in more than 6% of the cases, and a quarter of them had to be readmitted to theater, and the mortality rate. And the cost of treating the complications is about an extra 60% of having the operation itself. On the other hand, if a conservative approach is adopted to reduce the cost of having the tonsillectomy, the figures taken from the English hospital episode statistics showed a significant reduction in the number of tonsillectomies from 159 per 100,000 in 1991 to only 89 per 100,000 in 2011. This is about a 44% reduction. During the same period, you have made some saving from the reduced number of tonsillectomies, but the admissions because of tonsillitis rose more than 3 times. Admissions for quinsys rose by 31%, and the rate of retro or parapharyngeal abscesses increased by about 40%. So the gain from the bed occupancy rates because of reduced number of tonsillectomies was offset by the bed occupancy for the treatment of increased number of tonsillitis and complications. Not every case of recurrent acute tonsillitis should have a tonsillectomy, and Paradise has suggested some criteria to select those who need it. And his criteria, the Paradise criteria, was adopted by several national guidelines. These criteria are 7 episodes in a year, or 5 episodes of recurrent acute tonsillitis per year for 2 years, or 3 or more episodes per year for 3 years. Each of these episodes should have a high temperature above 38.3 and should have some pus evident on the tonsils, or have a new onset of painful lymph nodes in the neck, or detection of the streptococcus in a swab or by a rapid antigen test. The basis for the selection of the Paradise criteria as a cut-off point for deciding whether a patient requires a tonsillectomy or not is consensus-based. And the Paradise criteria are arbitrary cut-off points, a point at which consensus was reached, and it's helpful in guiding the decision making for choosing patients for tonsillectomy. But in 2000, the criteria was relaxed by the American Academy of Otolaryngologists and their guidelines in the 2000 guidelines. The guidelines was relaxed to only 3 or more attacks of tonsillitis or throat per year, despite adequate medical therapy. But about 10 years later, the American Academy has reverted its position to the original and the more stringent Paradise criteria. So these criteria are just consensus-based, arbitrary cut-off points. So what happened when restrictive criteria and policies were applied to reduce the number of tonsillectomies in practice? Taking this example from the UK, over a 20 years period from 1998 to 2017, and during these 20 years, 3 major landmarks happened. The introduction of the Scottish Intercollegiate Guidelines Network 34 and the SIGN Guidelines 117 later, and the inclusion of tonsillectomy and the procedures of limited clinical value in 2011. During this 20 years period, there was a very significant increase in the rate of deep neck space infections, including things like quinces, retro and parapharyngeal abscesses, and even infections of the mediastinum and other neck infections as well. All the figures had increased very significantly after reducing tonsillectomies. And the costs for treating tonsillitis and the complications of tonsillitis, like deep neck space infections, had also increased very significantly, as shown in this report from the Royal College of Surgeons in England in 2021. Before the introduction of the SIGN guidelines, which reduced the number of tonsillectomies, the total cost for a year for the tonsillectomy itself was 71 million, and for treating tonsillitis and its complication was just 8 million. Now, 20 years later, in the year 2017, the cost for doing the complication for the tonsillitis was 73 million compared with this, and the cost of tonsillectomy and treating the post-tonsillectomy hemorrhage is reduced from 71 million to 56 million, but that's offset by the huge increase in the treatment of tonsillitis and its complications. The argument for prophylactic management of recurrent acute tonsillitis started more than 30 years ago. This report from 1990 was randomized and controlled but not blinded trial, and the children used for the inclusion were those who have recurrent tonsillitis more than 4 episodes in a year. They took intramuscular benzene penicillin for 6 months versus no treatment, and the report showed usefulness of long-acting penicillin, significant reduction of recurrent tonsillitis. Of course, the long-acting penicillin has multiple drawbacks like hypersensitivity and anaphylaxis occasionally, and also the local pain, but this was a report in favor of prophylactic management of recurrent acute tonsillitis with antibiotics. Other arguments in favor of the prophylactic use of antibiotics to reduce recurrent sore throats came from the Scottish Intercollegiate Guidelines Network in 2010, where they examined 3 randomized controlled trials, and one of these trials showed no effect, but the other 2 trials showed significant effect, one of them for prophylactic use of antibiotics to prevent recurrent sore throats. The evidence from these randomized controlled trials included in the SIGN 2010 guidelines showed that benzalkonium penicillin, cefuroxime, and clindamycin are all superior to penicillin V in reducing the frequency of acute tonsillitis, and suggested that these can be used as alternative to surgery in those patients in whom surgery is either contraindicated or in patients who don't want to have the operation at this particular time. The evidence was modest for cephalosporins in reduction of the frequency of sore throats as well, but there was no demonstrated evidence in favor of macrolides, so only these 3 groups of antibiotics. Of course, the hazards of using long-acting clindamycin includes the antibiotic-associated colitis must be weighted against its efficacy. The SIGN 2010 guidelines had also suggested that you may use prophylactic antibiotics to prevent sore throat infections in closed institutions like, for example, army barracks or schools if there is an outbreak in there. An American study examined in this guideline showed that if children are infected, they can have a full 24 hours of antibiotic treatment before they return back to school or daycare to prevent or reduce the cross-infections. So antibiotics may be used to prevent cross-infections with group A beta hemolytic strep in closed institutions like boarding schools or barracks, but should not be used routinely to prevent cross-infections in the general community. The SIGN 2010 guidelines noted the extremely low incidence of rheumatic fever in the UK, although some outbreaks could be seen even in the United States. The numbers are still extremely low in the Western societies, and their recommendation was that sore throats should not be treated with antibiotics specifically to prevent the development of rheumatic fever and acute glomerulonephritis, but of course that may not apply to other societies in which the incidence of rheumatic fever is higher than the Western communities. However, 5 years later, in 2015, a Cochrane report applied very restrictive criteria to include randomized controlled trials on antibiotic prophylactic use in children and adults with recurrent acute sore throats. Among these restrictive criteria was that the follow-up period should be at least 12 months after the antibiotic therapy, and out of more than 1,300 articles, only 4 eligible studies could be found that had also some methodological errors. The conclusion in 2015 from the Cochrane was that there is insufficient evidence to determine the effectiveness of antibiotics for preventing, as a prophylactic treatment, recurrent sore throats. The Cochrane 2015 report on the evidence for prophylactic use of antibiotics in the management of recurrent tonsillitis applied very strict inclusion criteria, including that the follow-up period should be at least 12 months after the antibiotic therapy. Several other reports, including this randomized controlled trial in 2017, that showed some benefit of antibiotics and the prophylactic use to prevent recurrent tonsillitis. This report showed that azithromycin and benzalkonium penicillin could be as useful as surgery in preventing recurrent tonsillitis in children, but then the follow-up period was just 6 months after the treatment. And later, in 2018, 2 further randomized controlled trials reported superior clinical and microbiological effects of both clindamycin and amoxicillin with clonidine compared to penicillin. They had superior effects in reducing the recurrent episodes of acute pharyngotonsillitis. And they suggested in these two trials that antibiotic treatment is one option in patients with recurrent acute pharyngotonsillitis, especially when surgery is contraindicated or when the patients refuse surgery. This review from 2018 suggested that penicillin should not be used in some cases of recurrent acute tonsillitis, particularly cases with confirmed presence of beta-lactamase producing bacteria, and in cases of absence of bacteria with interfering capacity, like the normal flora in the pharynx, and in patients who had any previous failure of penicillin in the management of group A beta hemolytic strep, or in patients who have a recurrent tonsillitis caused by group A beta hemolytic strep in the community with high degree of unsuccessful treatment with penicillin because of the potential presence of resistant bacterial strains, and of course in cases with allergy to penicillin. The conclusion from the systematic review of 2018 was that tonsillectomy remains the recommended treatment options in patients with recurrent acute tonsillitis, but antibiotic treatment may be offered to patients who don't meet the criteria for tonsillectomy, or those in whom surgery is contraindicated, or if they are reluctant to accept surgery. It stressed that penicillin is not effective in eradicating group A beta hemolytic strep, the presence of beta-lactam producing bacteria, and should not be the preferred antibiotic option. Instead, a broader spectrum antibiotic like cephalosporin should be considered. The same conclusion was reached by the SIGN 2010 guidelines. Also, the group of patients who have a proven recurrent group A beta hemolytic strep should be offered surgery in preference to antibiotics. The numbers needed to treat is just 5.86. So this is the highest level of recommendation. The tonsillectomy is recommended in the case of recurrent severe sore throats in adults who have a proven group A beta hemolytic strep infection. I will now move to examine the evidence for the effectiveness of surgery in the form of tonsillectomy in the management of recurrent acute tonsillitis, with this Cochrane review in 2014, including 7 controlled trials, 5 of them in children and 2 in adults, with a number exceeding 1,000 patients. This showed that after 1 year of the operation, the children who had the surgery had 2 plus 1 episodes of sore throats, 2 episodes of sore throat plus the episode of pain in the throat after the surgery, compared to 3.6 episodes in the control group. The difference is modest at 0.6 episode in the first postoperative year, which translates to about a difference of 5 days of sore throats between the surgical group and the control group, who had 23 days of sore throats compared with 18 days in the surgical group. And the meta-analysis of the randomized control trials in the children showed this modest effectiveness of surgery compared to the control group. It also showed that children who had severe episodes of sore throats got more benefit from surgery compared to those who have less severe forms of sore throat. The results of the tonsillectomy in adults is more marked compared to the children. Adults who had the tonsillectomy had 3.6 fewer episodes of tonsillitis in the first 6 months after surgery compared to the control group, and had 10.6 fewer days of sore throat. The problem with this Cochrane review in the adults is that it did not include the postoperative complications for analysis, because some of these adults had complications in the form of bleeding or pain that may require to be added to clarify the real difference. And then recently came probably the largest comparative study between conservative management versus tonsillectomy in adults with recurrent acute tonsillitis. It came from the UK, and it randomized patients to either having surgery or conservative management, and the follow-up period extended to 2 years. This quite large comparable study showed that adults who had tonsillectomy had fewer days of sore throats compared to the conservative management. In the 24-month period, they had on average 23 days versus 30 days for the conservative management. The incident rate ratio for the tonsillectomy group is 0.53, just more than half that of the conservative management. It included figures for the adverse events in the case of the tonsillectomy, but concluded that tonsillectomy is clinically effective and cost-effective in adults with recurrent acute tonsillitis compared with the conservative management. And finally, we'll move to examine the quality of life implications of having tonsillectomy. With this study from Finland, prospective study using the tonsillectomy outcome inventory, 14 scores. This tonsillectomy outcome inventory examined the quality of life for patients who have recurrent acute tonsillitis. In the healthy population, the score would be less than 15 points. In patients who have mild symptoms of recurrent tonsillitis, it would be more than 20 points. Moderate symptoms would be 30, and 40 would indicate higher intense symptoms. The minimum important change in the score would be about a change of 10 points. When the tonsillectomy outcome inventory 14 was applied to the UK study, it showed a quite significant drop in the score after having the tonsillectomy compared to prior to surgery. They have a higher score, and that was reduced after 24 months to the normal level compared to the conservative group. The same result was obtained from systematic review concerning the impact of adult tonsillectomy on quality of life, which identified 8 retrospective cohort studies with more than 700 patients. It showed that tonsillectomy is likely to improve the overall quality of life, including in particular the physical and the general health domains. It was also noted in the SIGN 2010 that rates of patient and parental satisfaction with the outcome of surgery was above 90%. After being through the evidence supporting or against the 3 main options for the treatment of recurrent acute tonsillitis, it may be clear now that there is insufficient evidence to determine the effectiveness of antibiotics for preventing recurrent sore throats. Therefore, prophylactic use of antibiotics in the treatment of recurrent acute tonsillitis may not be recommended. In the societies where the acute rheumatic fever and acute glomerulonephritis is very low, sore throats should not be treated with antibiotics specifically to prevent the development of rheumatic fever, but that does not apply to other areas of the world with higher incidence of rheumatic fever or glomerulonephritis. Antibiotic treatment is an option in patients who have a recurrent acute tonsillitis, who have a contraindication to surgery or don't wish to have surgery at one stage. But tonsillectomy has clinical effectiveness and cost effectiveness when adults who have a recurrent acute tonsillitis compared with conservative management. The benefits of tonsillectomy may not show up very clearly except after 2 years from the date of the surgery, where the ratio of the incident rate ratio of total sore throat days may be almost halved compared to those patients who were treated conservatively. Also, the economic benefit, the economic break-even point for tonsillectomy is a little bit more than 2 years. So we are now finally back to the initial question of in the management of recurrent sore throats, who needs the tonsillectomy? And the answer from the evidence we've been through so far is that the advantages of having a tonsillectomy over conservative or prophylactic options would be much clearer after 2 years from the date of surgery. So the answer of the question may be this: if you have reasons to expect the patient to continue to have recurrent acute tonsillitis for the next 2 years, then tonsillectomy is certainly the better option. Now, we are good at identifying those patients who may not need surgery. Those are the patients who have 1 or 2 episodes of tonsillitis only per year. We are also good at identifying patients who definitely need surgery. Those are patients who perhaps have the Paradise criteria of having 7 or more episodes of tonsillitis per year. But there are 2 other groups here of false negative and false positive, in whom we have to think about not including patients in the surgical group who may not benefit much from surgery, and we should not miss patients in the conservative management group who perhaps could have been better off after the surgery. I think, and this had been echoed in several other articles and reports, that the Paradise criteria are too restrictive and may have to be revised, relaxed in favor of including more patients into the tonsillectomy group to avoid having all the problems of tonsillitis, recurrent tonsillitis, and its complications like Quins's, and suppurative infections like the deep neck infections, or non-suppurative infections like acute rheumatic fever or glomerulonephritis, and those areas of the world in which these 2 conditions are still prevalent. By this, we come to the end of this presentation on recurrent acute sore throats. Who needs the tonsillectomy? Assalamu alaikum.